So good evening, everyone. Today we are going to have a very interesting session. On behalf of Apollo Hospital, Navi Mumbai, I welcome you all to our this 31st teaching program on ventilator graphics, and hope it will be very useful to all our budding intensivists and anesthesiologists. So to introduce the session, myself, Dr. Gunadhar Padi, I am Senior Consultant Critical Care Medicine, Apollo Hospital, Navi Mumbai. So every Thursday or Friday we do such academic activity, and today we are lucky to have my own professor and teacher, Dr. Mrs. Bandana Lahiri, and Madam was ex-professor of Sion Hospital, Lokmanya Tilak Municipal General Hospital and Medical College, and she was my PG teacher, and she is also ex-professor and head the MGM Hospital, Parel. She had a vast academic experience, and she had many publications and textbook to her credit. And particularly, Madam is very much interested in teaching the ventilator graphics to all the anesthetists and intensivists who are just new to this field. And since we have a lot of our students who have joined this program, almost 45-50 students I am seeing in the chat box who are already joined this program. So I think it will be very much useful to all these people, and hopefully they can put all their queries in the chat box, and the end of this session we can take some of the questions. To begin the session with us today, we have my colleague Dr. Akhilesh Tandekar, who is also consultant intensive care medicine, Apollo Hospital, Navi Mumbai, and Dr. Divya. She is also a consultant intensivist at our institute, and we have two DNB fellows who are there, who can able to answer some of the questions if Madam has, and Dr. Pallavi and Dr. Ashwini. So with this, I just hand over the session to Madam, and Madam, we can start the session. Thank you.
Thank you, Gunadhar and Akhilesh, for giving me this opportunity. I'm really happy.
Thank you, Madam.
Now, what we're going to do today is learn ventilator graphics. What do they teach us? Okay. So now generally we see graphics on when patient is on mechanical ventilator. Okay, because we see graphics on the screen. Now this graphic is divided into scalars and loops. Scalars are generally, they are called waveforms. So it may be flow time, pressure time, or volume time. Loops are flow volume loops or pressure volume loops. Now waveforms, let us see how does the waveform of a spontaneous breath looks. That means if you connect a patient who is breathing spontaneously and you connect him to a ventilator, that means he is breathing normally as he would breathe from the ventilator circuit. Then the flow would look like this. Okay. Now we all know that normal inspiratory flow is sine wave pattern. So you can see that sine wave pattern over here. Okay. So this is inspiration. The flow rises, reaches a peak, falls. So this is peak inspiratory flow rate. Then here the inspiration ends, the expiration begins. Okay, the flow is in the reverse direction. Can you see? The flow increases, okay, and then reduces, but in the reverse direction. So this is what is expiration. Now, if you look at the pressure graphic, pressure versus time. See, this is time, this is flow. Flow in liters per minute. Pressure is always in centimeters of water, and volume is in ml. So if you look at the pressure graphics of a spontaneously breathing patient, it will be like, during inspiration, you can see patient creates a negative pressure, which is registered here. This is what we call it inspirative force. Sometimes we are told that kindly check the inspirative force of a patient. If it is more than -10, then you can wean the patient. So this is what is your inspiratory force. So the pressure will go to negative. If patient can create more negative pressure, it can still further go down. So this is what is inspiratory force. Then the pressure comes to positive side. Okay, this is expiration. So this negative is showing all inspiratory phase, and all the things on the positive side of y-axis is expiration. Volume. Volume curves are very simple. This is inspiration, this is expiration. There is not much to be learned from volume, except how much volume the patient is receiving, whether the volume is lost, and all that you can make out from the curves. Now, how will a waveform of a mechanical breath look like? Flow, can you see here? Flow rises, remains steady, and falls, okay? This is expiration, this is inspiration. Pressure, this is inspiration, this is expiration. And volume, obviously this is inspiration, this is expiration. So this is how a mechanical waveform, flow, pressure, volume versus time would look like. Now what is assist control mode? Now assist control mode is that patient will trigger the breath only if he creates a negative pressure, the ventilator gets triggered, which may be by pressure triggering or flow triggering mechanism. And only then the inspiration will begin on the mechanical ventilator. How would you know that? If on a mechanical ventilation, the pressure goes to negative and then comes to positive side, then these are called triggered breaths. So you will see this whenever patient is on assist mode. Suppose patient does not attempt triggering, then we have a backup mode. We always have backup mode on assist control mode. So assist versus control. So what happens that time? If patient does not trigger, after a preset time, the next mechanical breath will start, which is a control mode. You can see here, pressure doesn't go to negative, pressure remains steady, and next control breath starts. So you will know whether patient is triggering the breath or not triggering the breath, looking at the graphics. The flow graphics is difficult to make out, but pressure graphics you will know. Now let us see basis of a flow versus time curve. We all know that some ventilators provide you flow patterns, square wave flow pattern, decelerating flow pattern, accelerating flow pattern, and a sine wave flow pattern. But today's graphic, whatever I discuss, we will be completely seeing all the waveforms with a square wave flow pattern. Okay, so please keep in mind whatever I'm showing, it is square wave flow pattern. Okay, so inspiration. This is spontaneous breath. I showed you. How does it look? It will be sine wave flow pattern because ventilator is not giving anything. Okay, so this is spontaneous breath. Supposing I put the patient on CPAP. Now what happens? Can you see? Patient is on spontaneous breathing, but the flow pattern has changed from a sine wave, it has practically become a square wave sort of. Why? Because patient is given some kind of pressure in the circuit. Circuit is filled with pressures, whatever CPAP you have set. And from there, the patient is breathing. And hence, the graphic changes. The flow graphic changes in this pattern. Okay. And this is what is CPAP. Now, how much CPAP you are giving, that you cannot make out from flow graphics. You have to have a pressure graphics for that. So, mechanical breath. Okay. This is flow. This is called inspiration. This is expiration. This is time in seconds. Now, let us see the flow components. This is where it is beginning of inspiration. That means exhalation valve closes, inspiratory or demand valve opens. Why I say demand valve? Inspiratory valve is when you are on a mechanical control. Demand valve is when patient is breathing spontaneously. You call it a demand valve. Patient opens the demand valve and he starts a breath. So this is where the inspiratory valve opens, the expiratory valve closes. Okay, so the flow begins. Then the flow remains steady. I told you we are going to deal only with square wave flow pattern. So I have shown you that the flow is square wave. Okay, it is same constant flow all throughout inspiration. Now here the flow stops. Now this flow will stop depending on your setting of your frequency of the ventilation. Okay, and then here, can you see what happens? This is called peak inspiratory flow rate. This is where beginning of expiration. That means the inspiratory or the demand valve closes and the expiratory valve opens. So the flow goes like that, okay, almost flow in the reverse direction. Now the flow begins here, it is expiration. Okay, so this is called inspiratory time. This is expiratory time on the graphic. Okay, now let us see expiratory flow components. I told you this is beginning of expiration. The exhalation valve opens. This is called expiratory time TE. This is what is the duration of active expiration. And this is what is pause time. So this is what you will see on graphics. Flow graphics, if you want to see pause time, then this is what where you will see pause time. This is active expiration. Okay. And this is the total duration of expiratory flow. This is called peak expiratory flow rate. So now here is a comparison of CPAP versus mechanical ventilation. So CPAP, you can see this is how it will look, flow graphic, and this is the flow graphic of a mechanical ventilation. Now, if you look at the waveforms, spontaneous versus CPAP, flow graphic, you cannot make out how much is the CPAP level. But if you compare it, because all the three graphs will appear simultaneously on your ventilator screen. So this is what will tell you the CPAP level. And if you're looking at this, you will know that the patient is on CPAP. Okay. And volume, of course, doesn't matter much here. Can I know what is this? Dr. Devika is requesting remote control of your screen means what?
So anybody from students, can they make out this?
I'm just saying approve, okay? Let me see what happens. Okay. So now this is spontaneous breath. This is controlled breath. This is mechanical breath. This is assist control. I showed you all the graphics. You can take a screenshot of this so that this will tell you how to make out whether it is spontaneous breath, CPAP, mechanical or assist control. Now let us see how can you diagnose certain things, okay, for a flow graphic. Now here, okay, this initial what you show, I showed you in a square wave flow pattern, that is normal. If you are not giving adequate flow to the patient, for example, so many ventilators, they allow you to set the flow, inspiratory flow. If the flows are inadequate, how will you know? You will know from flow graphic. Can you see here? You can see little dents, means patient wants to breathe, but there is no flow. So you will see this dents on the pressure flow graphic. Okay. So this tells you that your inspiratory flow that you are providing is inadequate. Air leak. Can you see what happens? The flow doesn't begin from zero. The flow begins like that. Okay. Expiration is okay, but can you see the expiration supersedes here? It goes on the y-axis on the positive side. So this is what is air leak, because the flow that ventilator is provided is getting leaked out from the expiratory valve. So this is how a graphic will look of air leak. Is someone doing something? Because now somebody is putting in apps over here. Air trapping. How can you make out air trapping? Can you see? This is flow graphic. Okay, inspiration. Who is Dr. Devika and what is he requesting? I just don't know. Can you read this? Dr. Devika is requesting remote control of your screen.
So, Misbah, can you look into this? So I just request all the delegates not to scratch on the screen, because
And I cannot give remote control to that person because I will be controlling my graphics, my slides.
yes, ma'am. Yes, ma'am. You can, ma'am, continue. I don't think.
No, I'm declining, but what's happening, now see. Oh God. See, can you read this? This is coming in on my screen. Yes or no?
We are not seeing anything here, madam.
It is coming. Dr. Devika is requesting remote control of your screen. You can regain control at any time by clicking on your screen.
No, I think we have to deny the access.
I think let's deny that and we
But
can
every
go ahead.
time it is coming on my screen, so I can't read my graphics,
Dr. Dev, please, can you just do not do this? Do not ask for.
Who is Dr. Devika? Please tell her not to do this mischief.
Miss Wah, can you do the needful, please?
Okay, now how can you make out obstruction versus active expiration on a flow graphic? Can you see normal? Normal is this white, okay? So it would have been like this. If there is obstruction, can you see the flow? First of all, peak expiratory flow reduces. And the flow is very, very slow, Can you see here expiratory flow? It's rising slowly. So this is what is?
Madam, can I just interrupt, ma'am?
Yes.
So there are one or two requests. Basically, Dr. Madhuri has requested, like the previous 4 graphs. She wants to just need to have another look and take the screenshot.
Yes,
For
I
exam.
don't know how to reach the previous screen. Just a minute. Okay, I'll tell you. Previous.
So for the benefit of all the exam girls, basically these ventilator graphics, you just need to identify. In the exams, they will be giving you these screenshots on your OSCE station, particularly for the DNB critical care students. And you just need to identify what is the abnormality. So for that, you need to understand first what is the normal graph and then followed by the abnormality. So first you need to understand whether it is a mechanical breath or spontaneous
What's
breath.
this?
Yes. So if it is a spontaneous breath, whether it is a CPAP or CPAP with pressure control, if it is a mechanical breath, whether it is a complete your control breath versus the assist control mode. That is what basically this slide shows. So you just have to identify the abnormality. That's it. And anyway, we'll be uploading the lectures, ma'am, this with your permission, and so that for the benefit
Yes, my permission is there. Don't worry. Okay.
Thank you.
Okay. So now recognition of common abnormalities I showed you. Okay, this is what is active inspiration. This is what is asynchrony. Can you see? This is when your flow is less than adequate. Air leak I showed you. This is in liters per minute. Okay. This is what is air trapping. Okay, this is normal graph. And this is what is air trapping. Can you see the flow? Expiratory flow does not reach zero baseline. So this much is air trapping. Now, if you see on a pressure graphic, this will appear as auto peep. Okay, that means you will see some peep despite you're not giving peep. That means there is air trapping going on. Okay, this is when there is obstruction. So the next breath starts before the flow falls to zero. Now, this is what is obstruction versus active expiration. So this is what is obstructed flow. Okay. And this is active expiration, meaning patient wants to exhale more than what you give. So you can see peak expiratory flow rate increases, okay, and the flow falls very fast to zero level. Now, response to bronchodilator, you can see on flow graphics. How can you see here peak expiratory flow rate? This is long expiratory time here. And after giving bronchodilator, you can see here peak expiratory flow rate increases. There is shorter expiratory time, okay. Flow falls to zero, expiratory flow very fast. But how will you know this on a graphic? See, you will know this graphic. After giving bronchodilator, suddenly this graphic will appear. So how will you know? The way to know it is you have to superimpose. You know, you can have a track record of your graphics. So you can superimpose this on this. You will know that the bronchodilators have acted. So what all can you diagnose from flow waveform? You can take a screenshot or you can write your notes. So it is useful in detecting inadequate inspiratory flow, air leak, air trapping, obstructed breathing, and response to bronchodilators. So these things you can diagnose just on flow waveform, flow versus time. Okay. Now let us go to volume versus time. So this is inspiration. This is expiration. Okay. There is not much to be seen in volume versus time graphic. This is where it is beginning of inspiration. So the exhalation valve closes, the inspiratory or the demand valve opens, okay. The flow begins, and that is why the pressure rises, okay. Here it is beginning of expiration. Inspiratory or the demand valve closes, the exhalation valve opens. So this is where the flow begins to fall. So your pressure drops, okay. So this is what is your volume drops. You can see on the volume graphic. So this is what is your volume graphic. This is called inspiratory limb and this is called expiratory limb. Now, this will tell you amount of tidal volume on graphic. Okay. So this is what is your tidal volume. This is what is your inspiratory time. This is what is your total expiratory time. Out of this active expiration is this much. And this is your expiratory pause time, which you can see on graphic, on a volume graphic. How much is the pause time? Okay. Now, what common abnormalities you will see in volume versus time curve? You can see air leak. Can you see the volume does not come to zero? Okay. Now this is what is air leak. You can see active exhalation. For example, exhale volume is much more than what you had given to the patient. So this is what is called active exhalation. Now let us see basics of pressure versus time curve. This is the most important curve or a waveform on ventilator graphics. What all can you see? I showed you what happens on spontaneous breathing. Inspiration, you will see negative pressure. This is what is your inspiratory force or the peak inspiratory negative pressure. This is what is your expiration. Okay. Now, what does this show? This is pressure versus time. Okay. The pressures are not starting from zero. That means what you are giving is PEEP to the patient. Okay. This is inspiratory pressures. This is, mechanical breath. Okay. So this is inspiration. This is expiration. This is your peak inspiratory pressure here. This is your amount of PEEP that you are giving. This is inspiratory time. This is expiratory time. Now let us see spontaneous versus mechanical pressure versus time graph. This is spontaneous. I showed you how does the pressure graphic look on a spontaneous breath. This is what a mechanical breath pressure versus time graphic will look. What is an assisted versus controlled pressure versus time curve look like? I showed you that you will see this negative deflection just before the breath begins. And if it is not there, this is a control breath. So it is assist versus control. If patient doesn't attempt here, after a few seconds, the next breath will, mechanical breath will come. Inflation pressure, let us see components of inflation pressure. Inspiration begins here, okay? So the inspiratory or the demand valve opens, obviously the expiratory valve closes, okay? Here, the inspiratory or the demand valve closes, okay? So this pressure ends here, okay? Now what happens? What is this? I have kept inspiratory pause on the ventilator. So what will happen during that? That there is zero flow. When the flow is not there, obviously the pressure doesn't rise. But why does the pressure fall? Because this is the component of airway resistance. Because the airways are narrow, okay, so much pressure goes in overcoming the airway pressure. Then the alveolar pressure rises. Here, what happens? Flow is zero. Pressure comes here, okay. So this is inspiration. This is PIP, peak inspiratory pressure. This is P plateau or P alveolar pressure. This is called inspiratory pause. This is called trans airway pressure. And this is the exhalation valve opens. So please remember here, the inhalation valve has stopped, the exhalation valve has not opened, okay? The flow drops, the pressure drops. There is a pressure in the alveoli because exhalation valve has not opened. This is what is called plateau pressure, okay? So this is what is inflation pressure graphics, the components of inflation pressure. Now let us see components of inflation pressure little in a different way, okay? That was very complicated. Now here I have just shown you, inspiration begins, airway pressure is overcome, the pressure rises. Here it rises suddenly. Here it does not rise suddenly because alveoli are inflating. So the pressure doesn't rise suddenly. This is PIP, trans airway pressure, plateau pressure, inspiratory pause, exhalation valve opens and exhalation begins, okay? So now what is this component? Okay, if you look at this component, this is what is the work of breathing that the patient has to do to overcome airway resistance. And this is what is the work of breathing that patient has to do to distend the alveoli. So this is how you differentiate on a pressure time curve. And if you have kept inflation hold or inspiratory pause, then you can diagnose all these things on a pressure time graphic. How will you recognize certain abnormalities with pressure versus time curve? So let us see inadequate inspiratory flow. Can you see if the flow is adequate, it smoothly rises, okay, and then falls. But if it is inadequate, you can see the curve which is convex outside becomes flat. Now, earlier I showed you how will you diagnose inadequate inspiratory flow on a flow graphic. Well, this was the graphic. Okay, instead of being straight, it will be zigzag like this. So this is how you will differentiate when you look at the flow and the pressure curve, that the flow is inadequate and you have to increase the inspiratory flow. Now let us see PIP versus P plateau. I told you what is PIP. I told you what is P plateau pressure, right? So let us see if this is normal. Now what has happened here? PIP has gone up, but P plateau has remained same. Can you see this here? That means here is a patient who has a high airway resistance. Suddenly he has gone in bronchospasm and the graph has changed from this to this. Okay. That means if there is increase in PIP, if there is increase in trans airway pressure, but if the plateau pressure remains same, that means this is a case of increased airway resistance. Now, effect of increased flow. Even flow can change your PIP. This is normal curve. Okay, can you see here PIP has changed? Trans airway pressure is increased. Now, how will I know whether this is bronchospasm or this is high flow? Whenever there is high flow, you can see here the inspiratory time has decreased. Can you see inspiratory time, which was so much, and now instead of, see, green line shows you original inspiratory time, okay, because the graph was like that. Now the graph has changed, PIP has increased, but inspiratory time has become short, okay. So decreased inspiratory time compared to the previous graphics and increased PIP shows you that somebody has increased the inspiratory flow. Decreased compliance, how will you know? If the compliance decreases, please note, PIP increases, P plateau also increases, but trans airway pressure remains same because airway resistance has not increased. Okay. So increase P plateau, increase PIP, but same trans airway pressure will suggest you that this is decreased compliance. So maybe somebody leaning on the chest during surgery, let us say, or maybe there are a lot of secretions, the lungs have become stiffened and all that. So that is what is decreased compliance. So here are all your 4 graphs, okay, which I have shown. You can take a screenshot of this. This is normal. This is increased airway resistance. This is increased inspiratory flow. And this is low compliance. So how does the pressure waveform help you? It helps you in detecting or in altering. It helps in detecting airway obstruction, changes in airway resistance, changes in lung compliance, or changes in inspiratory flow. So you can alter the inspiratory flow. Lung compliance decreases, well, you have to find out means how to change the lung compliance. Airway resistance, you can alter it by giving bronchodilators and whatever you want to, whatever is suggested for that patient. So this is how pressure waveform helps. Now, can you diagnose modes of ventilation on a scalar graphic? We all know that all these flow waveforms, the waveforms, flow, pressure, volume appear simultaneously on graphics. Now, I want to know what kind of mode this is. So looking at this, I would say patient is not triggering, right? So it is a control mode. It is a square wave pattern, okay? So most probably this is mechanical ventilation. Now, please note, so far I just told you simple methods how to diagnose, but you must also know whether patient is on pressure targeted mode or volume targeted mode, because the graphics will differ on pressure versus volume targeted mode, okay? So let us first see pressure targeted modes because we are using it very commonly nowadays. So on a pressure targeted mode, flow, can you see? Flow is decelerating. Can you see here? Pressures are constant. And of course, here is a volume. Now, why do I call it a pressure targeted ventilation? Why should the flow fall? How do you set a pressure targeted ventilation? Okay, this is time cycle. That means patient is on a mechanical breath. Okay. He is not making any effort. He is not assisting you. Why should the flow fall? Now, please note, in a pressure control mode, what do? We set the pressure control level. That means if I have set it to 20 centimeters of water, the flow will immediately begin. It will remain 20. Ideally, the pressure will begin and the flow will be depending on how much pressure I have set. So the pressure, let us say, is 20 centimeters of water. So throughout cycle, it will remain 20 centimeters of water. That means the entire patient circuit is filled with 20 centimeters of water pressure. Now patient is inhaling, gases are going into the patient's chest. So what will happen? That the pressure in the circuit is 20. Okay. Originally, the pressure in the alveoli was 0. Now the alveolar pressure rises. Okay. So what happens? That the difference between the airway pressure or the mouth pressure and the alveolar pressure decreases. Because the pressure decreases, the flow decreases. Okay. That means any pressure targeted ventilation, you will see flow always in a decelerating fashion. So this is how you can diagnose whether it is a pressure targeted, looking at the flow pattern, looking also at the pressure pattern. Okay. Volume may not help you much because volume may keep increasing, decreasing depending on what kind of mode you are. Okay. Now let us see here. This is again a pressure targeted ventilation, but can you see here patient is triggering? Set PC level, pressures are constant, flow is decelerating. It is again time cycle. Time cycle because pressure control mode, okay, where I have set inspiratory time. So the flow falls to 0 almost, okay, by the time, whatever time I have set and pressures that I have set. Okay, so this is what is time cycle mode. Patient triggered mode, okay, pressure limited, and time cycle ventilation. Now what is this? Can you see? Patient is triggering here. So definitely it's an assist mode. Pressures are constant here. So these two breaths are pressure control modes. Okay. Decelerating flow. Suddenly something has happened. Now this is what is your SIMV mode. Okay. In between two breaths, mechanical breaths, patient is breathing spontaneously. So obviously this is your spontaneous pressure time curve. Volumes will be much less because it is patient's own volume generated. So this is a spontaneous breath. Okay, so this is how a graphic of SIMV will look like. Now pressure targeted ventilation. That means spontaneous breath. I am giving pressure support. Now please remember the difference between pressure control and pressure support is when patient is given some pressure in the circuit during spontaneous mode, it is called pressure support. It is not pressure control. Okay. So these are called pressure control breaths and this is pressure supported breath. So this is again SIMV because patient is triggering the breath. Okay. Whether mechanical breath, spontaneous, of course, he is breathing on his own, but he is provided some kind of pressure support. So this is your pressure targeted ventilation, SIMV mode. Okay. So looking at the graphics, you will know what it is. Now, what is this? This is again, CPAP is given on a mechanical breath. Okay. Now, can you see here? This is SIMV plus pressure support plus CPAP. Okay. Why I say pressure support? Because this is spontaneous mode, which is pressure supported. These are mechanical breaths and there is a CPAP. So this is SIMV plus pressure support plus CPAP. Now what is this? We all have learned of BiPAP. What is BiPAP? This is CPAP. Okay. Pressure time curve. This is our pressure control ventilation with PEEP. This is how the graphic will look. Now when patient is allowed to breathe spontaneously here during the inspiratory time, you call it BiPAP. So this is CPAP. This is PCV plus PEEP and this is BiPAP. Now let us see volume targeted modes. Can you see your flow is fixed? Whatever you have set, the pressure rises as the inflation proceeds. Okay. And this pressure will be dependent on compliance and resistance of the patient because this is a volume targeted mode. It is time triggered, means mechanical breath. Flow limited because you have set the flow, and it is volume cycle ventilation. When the set volume reaches, the cycle gets cut off. Okay. Now this is volume targeted mode. Can you see this is assist mode? Patient is attempting here. Now this is volume targeted. Can you see here? Patient is breathing. Okay, this is a triggered breath. Volume targeted because flows are constant. Pressure keeps changing depending on how much the patient breathes because volume is fixed. Okay, and these are spontaneous breath. So this is SIMB but volume targeted. Now, please note, these modes are called flow cycled. The spontaneous breaths that you give on a pressure support mode, they are called flow cycle. Why flow cycle? Because when patient is breathing spontaneously, he is provided some pressure support. Okay. Now the inspiration will continue till the flow falls to zero, right? You can't wait till flow falls to zero because it will be, maybe, so many minutes it will go on. So at some point you have to decide that how much the flow should fall compared to original when the cycle will break. So generally ventilators provide you that the cycle should break at the flow, 25% of original flow, 20% of original flow. And all this is there whenever you set the patient on a pressure support mode, you have to set this. The flow cycling at what fall, flow should, a ventilator should cycle from inspiration to expiration. That's why they are called flow cycle. All pressure support breaths, spontaneous breaths are flow cycle. They are not time cycle. They are not volume cycle. The volume will keep on changing. Okay. Now this is SIMV. Can you see? Plus pressure support, plus P, but this is volume targeted. Now what are common modes of ventilation? Let us see how they look. I showed you spontaneous mode will look like this. CPAP would look like this. Okay. Flow pattern, can you see the flow pattern changes in CPAP mode? Spontaneous is like this. The moment you give CPAP, it becomes almost a square wave because there is constant pressures, constant flow is there to give the sat pressures. So this is how you can differentiate between CPAP on a spontaneous mode and spontaneous mode. Control modes. This is how CMV would look. This is how assist control would look. This is how supportive modes will look. Okay. Say for example, your IMV. Can you see patient is not triggering the breath? So this is IMV, intermittent mandatory ventilation. Here the patient is triggering. So this is called SIMV. These are pressure support ventilation. You can see the pressure, set pressure remains same, but the flow keeps changing. But at a set flow, the cycle will get cut off. Okay, if original flow was that much, at 25% of the original flow, the cycle gets cut off. Your cycle gets cut off a little lower down because the original flow was less. Okay, here you can see. So this is called flow cycling mechanism. This is a set pressure level. And depending on the compliance and the resistance, the tidal volume will keep varying on the pressure support ventilation. Okay. Now, can you see what is this? This is SIMV plus pressure support. And this is SIMV because patient is triggering the breath. This is CPAP plus pressure support. Patient is on CPAP, but each breath is pressure supported. So you can see how the flow changes. From the square wave flow, practically it has now become a decelerating flow. The cycle gets cut off when the flow falls to 25% of original flow. This is a set PS level, CPAP level, and this is what is your volume graphic. So in summary, spontaneous breath would look like this. CPAP would look like this. Volume ventilation would look like this, where the flows are square, Pressure ventilation, always decelerating flow, and the pressures are constant. Volume will keep changing. This is PSV. Can you see each breath is triggered by the patient? There is no mechanical breath. This is pressure supported spontaneous breath. Now, whenever you put the patient on ventilator, the most commonly encountered conditions are high resistance or obstruction and a decreased compliance. Okay, that is of the lung parenchyma. What do? It will give rise to high PIP, over distension. Now, how do you know over distension? This over distension we can see in loops. Okay, we can't see on scalar graphics waveform. So I will show you how does the over distension look like. And air trapping, I showed you how we can diagnose on the graphics waveforms. Okay, this can lead to barotrauma, autopeep, or volotrauma. So ultimately, where do you use graphic? To keep a check on PIP, inspiratory flow, whether it is adequate. Inspiratory time, I'll show you one graph how to make out whether inspiratory times are adequate or not. Expiratory flow, expiratory time, and autopeep. So this is what you can detect on graphics. Okay. Peak inspiratory pressures, they may be increased in higher airway resistance, low compliance, higher inspiratory flow. If the flows are high, I showed you PIP increases. Okay. Higher inspiratory pressure slopes. Now let us see what is this high inspiratory pressure slopes. Okay. You know, some ventilators provide you pressure slope adjustment. So this is how the pressure should look like whenever you are adjusting. If your pressure looks like this, that means your pressures are high. Okay. Either the flow is high, which is giving you this peak. If the flow is less, it will give you like this. So pressure slope adjustment, basically what you adjust is the flow. Okay, at what rate the pressure should rise. Okay, so this is how you have to look for this kind of graph. Now here, insufficient expiratory time. What is happening here? Can you see here? This is inspiration. Okay, now ideally, the inspiration should end here, right? Instead, because of obstruction, the inspiration is ending here. Can you see? Now this generates autopeep here. Before the inspiration stops, because there is obstruction to expiration, can you see? The next breath begins here. Okay. Now the breath goes like that. Okay. Ideally, it should have been like this. Before the pressures come to zero, the next breath begins. If you look at the flow graphic, can you see here? Before the flow falls to zero, the next breath begins. This is inspiration, this is expiration. That means the flow is not allowed to fall to zero. The flow would have fallen to zero here. Before that, the next inspiration begins. So this is where you can, looking at the graphic, you can adjust your inspiratory time, expiratory time. You will know whether inspiratory time is enough, not enough. Expiratory time is enough or not enough. And autopeep you can see on the graphics. So this is what is insufficient expiratory time, which you can make out on the graphics. Now let us see flow volume loop. Now we always advise PFT. You know, what do they do here? They can tell you what is peak expiratory flow rate, you know, all those parameters they will tell you. They will tell you TLC, they'll tell you RV, but please know that this is what is inspiration, okay, when this graphic, and this is what is expiration. Okay. So in short, expiration is here and inspiration is here. Okay. But on a ventilator graphic, inspiration is here, okay, and expiration is here. Can you see? So this is flow in liters per minute. This is what is your peak inspiratory flow rate. This is what is your peak expiratory flow rate. And this is how the flow volume loop would look like. This is what is your tidal volume, peak expiratory flow rate. Now, how will you diagnose common abnormalities with this flow volume loop? Can you see here? This is what is your normal. Okay. If there is air leak, can you see exhalation will show you this scoop? Okay. It reaches baseline, but it does not reach your 0 point. So this is what is air leak in liter in ml. Air trapping. Can you see? Air leak was when this line came here. Air trapping is like this. That means it does not return to baseline. This will give you autopeep. What is increased airway resistance? Can you see? Expiratory flow. This is flow volume loop. Okay. This is inspiration. This is expiration. The expiratory flow, you can see it is peak has reduced and the flow also has reduced. If there is scooping, because the peak expiratory flow rate is reduced. This is a scooped out pattern, which you will see in obstructed airway. If there is water in the circuit, you will see a graph like this. Okay. So you know that you have to remove water from the circuit. Now pressure volume loop. Let us see what all we can learn from that. Okay. Type of breath. Can you see? This is control breath. Inspiration, expiration. This is pressure versus volume. Okay. So here is the volume. Here is the pressure. This is what is a graph of control breath. This is how an assisted breath would look like. Okay. The pressure moves to negative. Okay. Then this is inspiration and this is expiration. But a spontaneous breath would look like this. Okay. This is what is inspiration and this is what is expiration. Because inspiration pressures are on negative side, okay, and expiratory are on positive side. So it's exactly reverse of this. Now what all can you diagnose? This is pressure airway and this is volume. This is how the graph would look like. Okay. This is inspiration. Okay. You can see here the inspiratory pressure rise. Okay. Up to here. And then suddenly it rises because the volume increases. Can you see? So this is called the slope of a pressure volume loop. And the slope is important for you to diagnose many things. This is what is peak inspiratory pressures. And this is what is the tidal volume. Okay, this will tell you the tidal volume and this will tell you PIP. So points of change in the slope of a line. They are called inflection points. They represent sudden changes in alveolar opening and alveolar closing on a static pressure volume curve. Now I'll show you what is static pressure volume curve at a little later time. First, let us understand. You can make out work of breathing from this. Can you see here? A is called resistive work, okay, and B is elastic work. So work of breathing can be calculated from the area, okay, that is involved in this graph. Now P8W, okay, it represents the total work of the respiratory system, that is patient cum ventilator. Even ventilator works for patient, okay. PESO, okay, that represents pulmonary work of breathing. The elastic work is ABCA, ABCA. This is elastic work, okay. Resistive work is ADCA, ADCA. So this is what is resistive work, okay. This is inspiratory ADCA and expiratory is ACEA. This is, for those who are dealing with work of breathing measurements, this is what helps them. Now, how will you recognize common abnormalities with pressure volume loop? So let us see air leak. Can you see here? It does not return to baseline as far as volume is concerned. So this is what is air leak. Increase airway resistance. Can you see? Okay, this is called hysteresis. Okay, the lower slope. And you can see here it has expanded, it has ballooned out like that. So this is what is your increased airway resistance. Okay. Normal compliance is this, let us say. This is decreased compliance, okay, because to achieve the same volume, you require higher pressures. And despite higher pressures, the volume achieved is very less. So this is called decreased compliance. And the compliance increases. Can you see? This leads to decreased VT. Now let us see here 3 types of curves. This is green is normal. Can you see this is decreased compliance? This is increased compliance. Okay. So what happens? Now this is a pressure targeted ventilation. Okay. I am ventilating patient with the same pressure. The patient who is having least compliance, okay, he receives less tidal volume. Patient whose lungs are highly compliant, he receives higher tidal volume at the same setting of pressures. Okay. So PIP is same, but tidal volume keeps changing depending on the compliance of the patient. So this is what you can diagnose. Now I am on a volume targeted ventilation. What happens? I'm keeping the volume set for all three patients. Okay. Now what happens? This is normal. Okay. What will happen if the compliance is increased? He receives the same tidal volume at a lesser pressure setting. Okay. Means PIP are not high. If the compliance is decreased, can you see he receives the same tidal volume but at a higher PIP level. So with a volume targeted ventilation. Okay, so this is not, this is inspirative flow is less. This is how it will happen. And this is active inspiration. Your inspirative flows are okay, but suddenly patient wants to breathe more. Okay, so you'll get a dent like this on this pressure volume curve. Inadequate sensitivity. Now this is how, when patient is breathing spontaneously, this is how the curve will look like. If your sensitivity is inadequate, this will move much, much, much higher because patient is unable to breathe. Okay, so this will increase. This will increase, work of breathing will increase. It will move further here. Now, how do you decide how much PEEP to give? Can you see here? At 2 centimeters of PEEP, you can see the slope. Now, this is decreased compliance because at this much pressure, the volume achieved is only this much. If I increase my PEEP to 8 centimeters of water, can you see here the curve improves? The pressure volume loop improves because the compliance increases here. Okay, that means here is a patient who will benefit if I increase PEEP. The work of breathing will reduce here. Okay. Over distension. Can you see here? After a certain time, however much you increase the pressures, but the volume does not increase. So this is called over distension. So I should never see this peaking in my graphics, in my loop, pressure volume loop. If I see this, that means I'm damaging the lung. Because there is no change in VT, but airway pressure increases. Now, for example, if you have airway obstruction, let us say there are some kind of secretions here. What will happen? It will lead to over distension because whatever gases that you give, if you are on a volume control mode, please remember, pressure control, this will not happen. What will happen? There is over distension here and here there's atelectasis. So this can give you peaking. Now, see, this is what is your normal curve. This is a rise in pressure with little or no change in VT. So this is what is your distension, over distension. This is what happens in ARDS. There's hardly any change in the volume, but it is just picking, picking, picking. So if you see this curve, you are dealing with an ARDS patient. So it occurs with volume limit of some components of the lung, they will exceed an abrupt decrease in compliance at the termination of inspiration. And it results in a terminal beaking of the PV loop. So this beaking of the PV loop, you will see in ARDS. And whenever you are giving unnecessary high pressures, you will see. Now I told you, I'll tell you something about single inflation method. So this is what is done, on a ventilator to know the graphic, to know the static curve. This will help you in determining the inflection points, okay, lower inflection points, upper inflection points, and this will help you in deciding how much PEEP to give. Okay, this is normal hysteresis. Okay, this is abnormal. Okay, can you see here? So this happens in increased airway resistance or decreased compliance. PEEP versus PV loop. I told you how to determine how much PEEP to give. Okay, now this is optimum PEEP because you can see the slope. It's okay, adequate slope. Okay, FRC versus PV loop. Now what happens? Let us say this is volume. This is positive pressure, negative pressure. This is where our functional residual capacity is. Okay, this is what is your TNC. Now, can you see here FRC? Okay. So depending on the functional residual capacity, you can decide how much the PV loop will give you the slope. If FRC reduces, lung becomes less compliant and then your curve will reduce. If FRC increases, you may improve your curve. So that depends on your PEEP level or CPAP level. So trend in monitored variables are more important than absolute values. Now this is to be remembered whenever you monitor waveforms and loops. Aim is to institute appropriate therapeutic interventions as early as possible by analyzing the loops, analyzing the waveforms, but you must know how to analyze it. Thank you. Any question?
So thank you, madam, for excellent talk. I think this is very important, and this is the basic of any ventilatory management. And the students should be able to appreciate the different types of curves and different types of therapy they need to do for that particular troubleshooting. So in the exam, basically they will be given 3 or 4 loops or 3 or 4 your scalars. So they need to identify what is the type of breath and what is the abnormality as per the whether it is a spontaneous breath or it is a supported breath or it is a mechanical breath or it is a pressure volume loop or flow volume loop.
And plus, they have to know whether it is volume targeted or pressure targeted. That is also equally important, you know.
Yes, absolutely.
So even that they can diagnose by just seeing all these graphics. Okay.
So we have one comment from Sivaram Krishnan that it's a wonderful lecture. So again, congratulating you. And
Thanks for the comment.
Dr. Snehal also written that it's a very good lecture. Thank you, sir and madam.
Anybody has any questions?
So with us, Akhilesh and the benefit of the students.
Yeah, as Madam has rightly said, thank you very much, Madam. It was indeed a wonderful presentation, and I think you were absolutely thorough with the graphics, and this will definitely help the students to understand how to delineate the basic problems, basically. So we get worried about the different abnormalities of the waveforms as far as the graphics are concerned. But when we go through such lectures repeatedly, probably then only we will be able to understand thoroughly. Just attending one lecture or reading once or twice is not enough. This is my own personal experience.
Yes,
I have been through these graphics on several occasions, and we need to polish it up ourselves. At this moment also I am able to read and learn a lot of abnormalities in the graphics, so as it is true to everyone as well. And besides this, I think the trends of the graphics are also very important. We cannot just pinpoint on particular graphics that we need to act upon immediately, but we need to see the trends as to how the trends are going.
you have to see the trend
And then we
superimpose.
Yes, I agree with you.
Superimpose, then you will know what it is.
Right.
Yeah, sometimes we overdo it or sometimes we underdo also. So, but if we keep on monitoring these trends over a period of time, then only we will be able to understand the compliance of the patient, the resistance related issues, and the abnormalities. The basically what we need to understand is how is the compliance and the resistance. These two things are very, very important to understand.
Yes.
And these abnormalities will definitely give you a subtle idea about the compliance and the resistance. But there are several problems, like as you said, that if there are oscillations, we will be able to understand whether the patient is triggering. If there are secretions, we will be able to see the serrations in the waveforms and all that. So that will help us to guide our nurses also as to when do we need to do suctioning, when do we need to act immediately and all that, and when do we start weaning the patients. So for that we need to be absolutely there with the patient bedside, and then only we will be able to do a justice with the patient management as far as weaning of the patient from the ventilator is concerned, and proper management of the patient on ventilator is concerned, we need to be there, standby, bedside with the patient, and not just giving orders is sufficient, but being there with the patient is more important.
So here one questions I would like to ask Dr. Pallavi, and also I want the opinion of Divya, how to differentiate between auto PEEP and air trapping on graphics. So any take on message like in which conditions basically we find such kind of auto PEEP and air trapping, and why they are very important? Because for intensivists, this is the one of the most important thing when we ventilate a patient of COPD or asthma, and we give them inadequate expiratory time. And in those cases, we sometimes see a graph, what actually madam has shown. So that is very important. So Dr. Pallavi.
Pallavi has answered COPD patient.
Yeah.
COPD patients most commonly when they're having obstructive pattern, they can develop into they can trigger auto PEEP, sir. When there is inadequate respiratory time, which will add on to the which will correlate with the inspiratory cycle of the ventilator, which doesn't allow the enough expiration to happen, which will lead to auto peeping.
So how do you basically correct all these auto PEEPs, and what are
the respiratory rate or increasing the respiratory time, IE ratios?
What does that mean?
I would like to say one thing. What she said is auto triggering. Now, auto triggering happens whenever there's auto PEEP. Because if your patient is on triggered mode, okay, and let us say you have set your level. If you are giving 10 centimeter PEEP, okay, and your triggering sensitivity should be always little less than PEEP, right? If my PEEP is 10 centimeter and if I give triggering sensitivity -5, that means patient has to create 15 centimeters water negative pressure to trigger the ventilator. So what do? I keep my triggering sensitivity +5, correct? Not negative like in other cases. Now what happens? If there is an auto PEEP, okay, what will happen? There may be auto triggering because I'm not giving any PEEP, but I've kept my triggering sensitivity +5. And if the auto PEEP occurs, okay, what will happen if my expiratory times are less, there will be auto triggering. Means before the expiration ends, the next inspiration begins. And that is how auto PEEP will increase. So this is very important to take care of auto PEEP on a ventilator graphic. You must know what is auto PEEP. It can lead to auto triggering.
correct?
Yeah. The auto PEEP is quite significant enough, then it will be quite advisable to disconnect the patient from the ventilator and just go on with the settings and increase your respiratory time, reduce tidal volume, and probably you may have to increase the flows. If you increase the flows, the inspiratory time will get shortened and expiratory time will be prolonged. So that is how we will be able to treat auto PEEP or
So,
intensive.
so what is the ideal trigger we should keep actually on ventilator, like flow trigger and pressure trigger, and what is their importance, ma'am? This is mostly asked by many of the junior trainees.
Yeah, nowadays you get ventilator where there's flow triggering. Okay, that means what happens, it nullifies your work of breathing because patient doesn't have to create that negative pressure to trigger the ventilator. Okay, and flow triggering, there's some kind of flow passes through the expiratory phase. Okay, from which if patient takes little breath, it amounts to that patient wants to breathe, and automatically the ventilator will trigger into inspiratory phase. So it will reduce the work of breathing if you are using flow triggering compared to pressure triggering.
So flow trigger
And
is
patient is also more comfortable with the flow triggering rather than the pressure triggering.
All the newer ventilators provide you both pressure as well as flow triggering.
so normally I think there is a bias flow which is always circulated in the circuit.
Correct. That comes in both flow triggering. You need a bias flow. That is a mechanism of flow triggering.
Yeah. So anytime the patient triggers, then if the flow goes down less than the bias flow, probably the ventilator triggers.
Correct.
So if you keep the triggering very high or very low, sometimes it not solve the purpose. So we need to. Yes, ma'am. So we need to keep certain level of triggers. Like ideally on flow trigger, we keep usually 2 liter to around say around 5 liters, in between 2 to 5 liters. Probably the less we keep, it is better, so that that the patient should not be over triggered also and under triggered also, and this is sometimes lead to double triggering also. So
Yes.
that is why the trigger valves are very, very important. Madam, any experience with the this pediatric ventilation with the uncuffed tube? Does this graphics are same or still you need to have some different category of graphics?
Graphics may change, because uncuffed tube, there will be a lot of air leak, So accordingly, you have to set. But my experience with pediatric ventilation is niche because I've never ventilated patients. I mean, pediatric patients in our recovery room or ICU.
But then we should be able to assess how much is the leak. And now ventilators have got the facility to compensate for the
Leak
leak.
compensating mechanisms are there and all that you have to set. That is true.
So, but for that, we need to know how much is the leak exactly. So you just ventilate the patient and find out how much is the leak. If it is 50 to 100 or so, I mean, probably for adults, it may be acceptable. 50 leak may be acceptable.
And then
for pediatric, but
accordingly, you
for
have to set
pediatric
your
patients,
alarms, because if your alarm is
yes, alarm,
normal and, if there is a leak, it may give rise to some kind
yeah,
of auto triggering.
yeah.
Alarm
And
setting is
pediatric patient
important.
leak of, yes, yes. And in a pediatric patient, the leak of 50 is also quite significant.
Yes.
We can't accept. So that's why leak compensation, has to be there, and it has to be monitored.
I think we
So
don't have
one,
further. So we can.
one more point is like, if the trigger is so sensitive that patient will keep breathing, and we have seen, if the trigger flow is kept like 1 or 0.5 or something like that, we have seen the patient breathing more often,
That is only
especially
auto
when they are
triggering.
coming on
It is
the
auto triggering
yeah, yeah,
and it will give
yeah,
rise to
auto triggering, and that
So,
can also lead to auto
so
triggering.
sometimes
So that's why,
in the exam we might get a graph of auto triggering or double triggering. So those kind of graph may be there for the exam going students, and the examiner used to ask them and how to troubleshoot them and how to correct the abnormality. Sometimes these may be important questions.
yes.
and major advantage of the graphics is to identify the plateau pressure and the driving pressure. That is what we do in our day-to-day practice. We're ventilating patients with the ARDS. We should be able to identify how much is the plateau pressure and all that. Madam has already, discussed different ways of finding out the plateau pressure. Even with the inspiratory hole, plateau pressures can be monitored and measured. So one of the advantages of graphics is monitoring plateau pressure, driving pressure in ARDS patients, and for COPD patients we need to monitor autopsy. So these two things are very important. No matter which mode of ventilator it may be, it doesn't matter what mode we have. And several studies have also shown that mode doesn't matter, but what matters is how you limit tidal volume, how you set PEEP, optimum PEEP needed for the patient, and how do we set the trigger sensitivity. And then FiO2 and other parameters also has to be adjusted, depending upon the patient's requirement. At times we go on, ventilating patients with the adequate settings. Your PEEP is adequate, tidal volume is also adequate, but we don't look at the FiO2. We end up giving a lot of oxygen to the patient, and that leads to atelectasis, and that could also be a reason for difficulty in weaning for some of the patients. So each and every parameter on ventilator, whether it is tidal volume, PEEP, respiratory rate, I ratio, trigger, sensitivity to FiO2, all these parameters should be adjusted according to the need of the patient. And we need to take into account patient's compliance and the resistance parameters. Now, the sophisticated ventilators are good enough to identify the compliance and the resistance.
Yes.
And these ventilators have got the facility to adjust the tidal volumes also according to the compliance and the resistance pattern. So this is one of the advantage, but we can't be completely relying on the machine. We have become machine dependent, ventilator dependent. Okay, so but we need to have our own understanding as to how do we adjust ourselves also. We should not be dependent on the ventilator. So good times have come. Advanced machines have taken over a lot of our work, but our own understanding is also very, very important. That is what I would like to suggest to all these students.
So thank you for such an wonderful lecture, madam, and
I
from
also thank you for giving me this opportunity. I had this graphics on my
Thank you very much.
computer waiting,
yes, ma'am. Yes.
somewhere.
Yeah, and
So,
it's indeed such a long time we have seen you. I mean, after maybe almost 8 to 10 years that we've seen you, but
Yes.
we've seen you at least virtually, and really, it's wonderful to see you, madam. Thank you.
Thank
It was an honor and privilege for all of us on
Yes.
behalf of
Thank you.
thank you. Thank you. And with this, I am closing the session.
Yes.
And hope to see you next session on Thursday on hemodynamics monitoring. Madam, I will send you the link also.
Sure, sure.
Thank you, madam. Thanks.
Thank you very much, madam. Thank you.
Thank
Bye
you.
bye. Good night.